Okay. So again, this couple just joined. Good morning, everyone, and welcome to EM Skills Academy practice session today. We're having today an orientation about MRCEM OSCE exam for our colleagues. There was a high demand from our colleagues to do this session again. This is our second session. And today as well, we are going to practice a 4 MOOC station similar to the exam setting, just to get you a bit of taste of what you are gonna face in the exam, guys. Um, so I will just start with introducing our faculty today. So my name is Khaled Khalifa. Call me Khaled. I'm one of the A&E consultant, work in Manchester University, NH Foundation Trust, based in Wisenshaw Teaching Hospital. Okay, George?
Hi, I'm Georgina Robertson, and I'm a clinical director and consultant in emergency medicine at East Lancashire Hospitals Trust. Nice to meet everybody.
Mehdi?
Hi, my name is Dr. Mehdi. I'm a consultant and deputy clinical director at East Lancashire Hospital. And along with Khaled, we are directing this course. Nice to see you.
Thank you. Hamid?
Hi, I'm Hamid. I'm one of the A&E consultants in Lewisham and Greenwich Hospital, South London. Welcome, everyone.
Thank you for joining, everyone. So let's just make a start. So today, as we said, like we're doing an introduction for specifically OSCE exam for MRChem. We are EM Skills Academy. We've been doing these courses for long now. We started with kind of free courses since 2016. We've done a few courses in Saudi Arabia, in Ireland, and in the UK as well. But in the last couple of years, we started to establish the academy and do more organized courses. So today, as we said, we'll do a quick orientation about the MRChem exam and a few sample station as well, and we'll take your questions. I'll try to answer it. So what we offer in our academy, we do face-to-face courses in MRChem OSCE for MRChem OSCE and for FRChem final OSCE as well, along with some online courses as well for those who can not attend the face-to-face course. As well, we've done 3 interview preparation courses for our colleagues who are attending ACCS interview and higher specialty trainee interview courses. And most of our candidates scored high and get their first preference in the first go after they had the interview. As well, we do a free career consultation. So if you guys thinking about emergency medicine, if you are overseas as well and want to move to the UK and join the emergency medicine team, so we got this free consultation, free career consultation. You can book it through our website, www.emskillsacademy.com. And then one of our consultant will give you a call. You have a 20 minutes to discuss your personal circumstances, give you a proper advice, and help you with your exams, with your career, with your journey, with your move to the UK. And it's all free for you guys just to help you to get you in the emergency medicine career. We got an extensive experienced faculty, all consultant based in the UK with an former RChem examiners as well. Will get you pass easily, hopefully in the first go for all your exams. So our upcoming courses, we conducted a very good course, successful last month, and we're having a face-to-face course in Burnley General Hospital just this at the end of May, 24th and 25th. It will be face-to-face in Burnley Hospital, same suite. It will be extensive 2 days course, 1 day practice in a small group, a lot of teaching. You'll take 20 station in 1 day, and then the second day will be a proper MOOC exam, 16 station, similar to the exam you're having as well. And then we are going to Hyderabad as well in July for the next diet. Sorry, guys, I'm just admitting people as well. So keep an eye, Mehdi, on the lobby.
Yeah, I'm
Okay.
admitting.
Yeah. So next course face to face, we've got one in the end of May at UK Burnley Hostel, and then we've got July one at Hyderabad as well. So why our courses are different? As I said, we've got the faculty UK-based, all NHS consultant, very experienced, former RChem exams. We get real exam-like scenarios, so get you the taste of the exam, what to expect, and then we try to shape you, enhance you, give you a bit of personalized feedback, okay, to improve your performance. Fine. So let's start now our first topic, which is a bit of orientation about MRCEM OSCE exam. And I will leave the mic to Mehdi to take over now and to get you through these, guys.
Thank you, Khaled. Thank you very much. Thank you, everyone, for joining today. Let me quickly go through a few slides, just orientation about MRCEM exam. It's just for those who have not appeared yet, and even for those who have already appeared, I'll tell you insight of what we do at Royal College as examiners. So as you all know, it's a practical exam, and the format is OSCE and 16 station. Normally it's 16 station and 2 rest stations. And timing is 2 hours, 42 minutes. That means 8 minutes for each OSCE. So with a 1 minute of reading, and then you have 2 rest stations. So location MRCEM is conducted in London, it's in Malaysia, Chennai and Hyderabad, and Kochi, sometimes in India. And next slide, please. All right, okay. How domain-based marking works. So you might all know it used to be checkbox, tick box like system before we started the domain-based marking a few years ago. So as an examiners, when we mark you, how we mark, this is the domain-based marking we recently started. Normally, each station will have a couple of domains to be tested. So if you look at the pie charts, in pie charts, no, go back, keep it there, go back. Yeah. So once you look in the pie chart, it will have 3 or 4 or 2 sections. So those are basically domains which we check you in the exam. So do not think it's an history station, only your history taking skills will be checked. It will have definitely 2 or 3 domains. We might check your communication skills, conflict resolution, and something else. So those are the domains. So each OSCE station will have at least 2 to 3 or sometimes 4 domains which we mark, and you have to perform in each domain separately. Then domains are skills which candidates are expected to demonstrate within each station. That's fine. Next one. Then how many domains we check in MRCEM? So in MRCEM we have seven domains to check, and in FRCEM we have 8. There are 2 additional in FRCEM. We'll go through that shortly. So first domain, what we check is clinical reasoning and decision making. Second is practical skills if it's a procedure, then communication skills and conflict, then teaching skills, then history taking and information gathering, or most of the station will have a bit of history taking and information gathering most. And then organizational prioritization and clinical examination skills. So each station will be mix of these. It could be 2, it could be 3 of these domains, and they all will be marked separately. Do not think that if it's a clinical examination and you have done the examination, you will be examined for examination skill only. No, there will be 2 or 3. Next. Then again, FRCEM, just leave this. In FRCEM, we have 2 extra, research and data management. Leave this one. Go to next slide. All right. So as I said, each OSCE will have 1 to 4. It could be 2, 3, or 4, and each domain will be separately weighted. Next one. This is the marking scheme. When we mark you in college, the examiner will be sitting in the room. He doesn't have marks like 1, 2, 3, 4. He has these, buttons on the iPad. He has to click one of them. Whether you have scored very high, he will just click on well above the level of the competency. If you have scored very low, he will click on well below the minimum, and there are 3 more in between, like minimum level of competency, then above the minimum. So it depends upon your performance. He will click on these. Next slide. So once he will click on these, the computer will automatically calculate the numbers you have achieved in that station. It's slightly difficult for you to understand, but normally we do not say each station has 10 marks. We do not write mark 1, 2, 3, 4, or 10. We just click on these buttons, and then computer will itself calculate your marks. Next slide, please. Then again, it depends, the each station, the marking scheme, it depends upon the examiner's judgment. He looks at your performance in each domain, not only the whole station. He does at whole station as well, global score, but in each domain. Next slide, please. Okay. Important thing is each exam day is a separate exam day, and each exam is a separate exam and separate pass marks and possible different stations. So here's a good tip for you. If you are on day first and you have told your colleague the questions, which you should never do, even for example, if you came to know about the questions, so do not think same questions will be repeated. When we set up the questions, we set up each question will have 3 substations prepared. So what happens is, if first day, for example, I'll give an example, there is a question about limping child, same age, 5 years old child came with limping to emergency department. Can you go and take history and examine the patient and tell the management? This station will be there for all 14 days. But once you go inside, first day, it will be maybe Sophie. Second day, it could be Perthes disease. Third day, toddler's fracture. Fourth day, it could be reactive arthritis. So, but the scenario outside is same, marking scheme is same. It is the actor and the examiner's assessment on that day. So, for example, if first day you came to know, oh, it is Sophie there, and next day you are preoccupied that, oh, I know this station. It's same. I have its age is same, 5 years old child coming with limping, it could be same. And if you do this blunder in exam, you instead of it might be toddler's fracture or it might be reactive arthritis, you say the same what was first day. Examiner will be suspicious. He will mark you. He will click on, there's a one tab called red flag. If 3 examiners in a whole day will mark you the red flag, then you will be investigated. So just go with open mind. Do not get preoccupied that you know the station. Even if you know it, I'm telling you, when we give the station to the college, we keep, for example, if I am preparing for NSTEMI or say chest drain station, I have to give them 3 separate similar sessions prepared, so that outside the question will be same for every day and the marking scheme will be same but slightly different scenarios. So do not get preoccupied. Every day is a different exam. Okay, so 1 minute preparation, very, very important. So you got a 1 minute preparation once you read. That's not only for reading. Normally we keep scenarios very short. So the 1 minute when you go and read that station is basically a deciding factor whether you will pass that station. The 1 minute, just you can, 40 seconds, you will read the scenario, have a look at the pie chart, how we have distributed the domain wise, in that. Is this station asking me history taking, information gathering? Is this asking me in addition to that examination? Is this asking me conflict resolution? Have a look at pie chart. Or then again, think about your structure, which structure you are going to put in. For example, if you have read, you have to teach F2 ECG. So get your ECG structure into your brain in that. So I will introduce, do this, and then tell him what you know. So everything should come to your mind in that 1 minute. That will be deciding factor whether you will pass or fail, and leave behind what you have done in the previous session. I think that is end of this presentation, and we will move to scenarios now.
Thank you, Mehdi, so much. Thank you for this useful insight. Okay, guys. I just want to echo Mehdi about this 1 minute. It's very, very important. So the scenario itself is short. It takes like only 10 seconds. But this minute is very important to read the scenario, have a proper look to the pie chart, know what is the task, and then start to draw your structure to approach the station. This is how you use this 1 minute. Okay. And now we are going to have some fun. Okay. So practice. We'll do 4 stations. So we've got 20 candidates here. Good. Hands up, who's having his exam shortly? That's Muhammad Raza. Yeah, anyone else? Yeah, Muhammad Iqbal, Joher. Okay, so got few candidates then. So got 4 stations. Today we're doing 4 stations. So you can just open the mic and let me know who want to be the candidate in first station. Axel, more hands up now. Shall I choose?
I don't
So
mind.
Yes.
Is that Raza?
Yeah.
So Raza will be candidate for first station. And then we got Aksa, hands up as well.
Murtaza.
Murtaza, 2.
So
Station 2.
put Aksa for station 2. She is yesterday finished her ETC. Let's see how she has done there.
Okay. Fine. So Aksa, station 2. Murtaza, station 3. No pressure, Aksa. Don't worry.
I can do one station as well. Muhammad Akil.
Akil, 4. All taken now, guys. Okay.
So these are all our candidates who have chosen the station or doing the MRCEM.
Okay, good, fine. So what we're gonna do now, the same what we do in our online courses. So we'll do similar to the exam setting. So for 1 minute, the scenario will be in the screen. We'll let you know. Now start. So when I say start, that means you start reading. You got 1 minute. Have a proper look. Read your scenario. Have a look to the pie chart. Know what is the task. What is the domains you're gonna be assessed against. Okay. Draw your plan, and then I will say another start, which means you're going inside, and then you will start to interact with an actor. Okay. There will be one of us as an examiner. Don't interact with the examiner at all. Just start to interact with the actor for 8 minutes, and then we'll say finish. When we finish the station, we'll start to give you the feedback. Okay? Everyone happy with that? Fine. So now our first station, Dr. Hamid will be the examiner instructor giving feedback. Mehdi gonna be the actor, and our candidate is Raza. Are you ready, Raza?
Yeah.
Perfect. Let me just put the timer on. Start. Start.
Hello, hi, I'm Dr. Raza, one of the emergency registrars. Are you Dr. Mehdi?
Hi, I'm Tom. I'm one of the F2 doctors in the department.
Hello, Tom. Nice to see you. How's your day?
Oh, thank you. I'm doing well.
Right, Tom. So I understand you've got a patient for a facial iliaca block. Is that correct?
Yeah, I have seen one patient, I checked X-ray, which is having a right nerve. So I'm very much interested, to do, facial like a block. I have never done it before.
Sure, perfect. We'll go through together, and hopefully at the end of the procedure, I would be able to explain. During the procedure, I will be able to explain the practical bits of it. But before we start, just a quick recap of who is your patient and what happened to him.
Yeah, patient is basically 69-year-old female, Jessica. She had a fall today morning in bathroom, and then she was unable to mobilize. Ambulance was called and got here. I have seen her. One of the consultant done primary survey and then requested X-ray hip and pelvis. So I check it now. So yeah, there is a right side no.
Okay, right. And have you seen the patient yourself?
Yes.
Perfect. And has this patient had enough painkillers?
Oh, yeah. Immediately started, the knock bundle, which says give paracetamol first, then morphine. So I have given so far paracetamol 1 gram.
Okay. And is this patient alert and conscious?
Yeah, of course.
All right. Okay. So, and you've seen the X-rays. Have you seen the X-rays and
Yes. Yes.
confirmed that this is a NOF?
Yeah, I have seen X-rays, and X-rays are reported by the radiologist as well. So yeah, it's confirmed now.
Right. Perfect. So before we go into discussion about facial iliaca block, what do you know about the block?
Honestly, I have seen one of the registrars doing it before, and he told me normally we do it to minimize the pain. Yeah, but I don't know much about it, honestly.
No problem. We'll go through the details in a minute. Right. So let's set some goals for today's teaching. Basically, we need to know like what actually is a block. So this is a regional block that we give. We'll go through the indications then, like what are the conditions where we need to give this block to the patients. Then we should familiarize with ourselves with the equipment that we need. Some
Okay.
and sometimes we might need ultrasound guided blocks. It's either landmark based or ultrasound based, but we'll go through both of them.
Yeah.
And most importantly, we should be knowing the structures that we will be intervening, and like because this is a nerve block, so we should be knowing what nerves are we going to block and
Mhm.
what kind of analgesia we're going to achieve. So these are few simple goals for this teaching today. So let's go and do this. So first of all, let's see what is a facial iliaca block, compartment block. So basically, it's self-explanatory. We are basically going into fascia iliaca, put some local injection in, and we aim to block a few nerves. Do you have any idea which nerves do we aim to block?
Oh yeah, he told me that day it is fascia like sorry, it's the femoral nerve, obturator nerve, and the third one I forgot.
Okay, so yes, you're right. It's a femoral nerve, obturator nerve, and uh, I'll double check. I think it's lateral cutaneous nerve
Oh
of the.
yeah, it is lateral cutaneous now. Yeah, these three. Yeah.
Wonderful. Right. So then is we need to know the landmarks, which landmarks we are going to use. So if we go and see the patient, so basically what we do is there is one is landmark technique
Mm-hmm.
where we put some identify some landmarks. So
Mm-hmm.
but before we do that, we'll explain this to the patient, what we are going to do, what is
Mm-hmm.
the purpose of this block, and it would be ideal if we obtain a verbal consent for that. Make sure we have an ECG in place for this patient, and make sure we have seen the ECG.
Okay.
The second step is we identify the patient landmarks in the presence of a chaperone.
What are the landmarks like?
Fine. So we need to identify a midline between anterior superior iliac crest and
Fine.
pubic tubercle. So we need to draw an imaginary line between these two structures, and we are going into the it's so basically it's lateral 1/3 and medial 2/3 that
Oh,
we,
yeah, okay. Yeah,
and
yeah.
1 centimeter below this point we would be going into. So in terms of equipment, so we need to have an ultrasound machine ready for us.
Okay.
And we need to have, so we need to identify which agent we are going to give. So we will have some lidocaine with us to numb the skin so that when we inject our main needle.
Why we need ultrasound?
Fine. So there are few. First of all, it's under the vision. It helps you make sure you do not go into any vascular structures, and mainly that's the reason for going with ultrasound, and you actually seeing it with your eyes what we are doing. Now, for example, if someone is taking any blood thinners, it would be ideal if we go with the ultrasound so that we are sure we are going into the right place. So now, the injection, like the agent that we need to use is mostly levobupropion. We should have our safety lock steps that we go through and make sure we are doing all the right steps in the right direction. Is
Yeah.
that clear so far? Any questions, Tom?
Yeah, I just you said levobupropion. So is this the only drug we use, or we can use any other, and what dose we should normally use?
Okay, good questions. We would go through together if we have any alternative options apart from levobupropion. Right now, it's on the top of my mind. I will have to go through together through the guidelines.
Okay.
Now it is weight based for the levobupropion. So we have to weigh the patient and then do it according to the weight base. After the end of the discussion, we'll go through like what quantities of the drug we need to give to patients.
Right. Okay.
Uh, any other questions so far?
Yeah. So is there any technique for doing ultrasound, or it is just to, you said it is just to visualize. Is there any set?
Time. Move to the next station, please.
No, let's give feedback first.
Yeah.
Hamid.
Hi. Yeah. Hi, Dr. Muhammad. You are mute.
Hi,
Yeah.
Doctor.
How did you feel?
I think time management was the main issue, plus a bit more detail of the in terms of answering the questions you need to
Yeah.
have.
I think definitely time management is good to have that insight. Definitely time management. The issue is that you have to do the task. You are very good, actually. You're teaching, so the way you do it, you engage, you ask for questions. That's exactly what we are looking for. We don't want to be a person who will start and doesn't stop till he finishes. That is not, but you have a right way, but it's just the time management, because sometimes you are going into this. So the whole idea of these exams is, if you do the same questions for whole day, you will pass. Everybody will pass. Is that the stress? The 8 minutes, how you manage your time? That's crucial, and that is when we said in the 1 minute, you have to decide how to go. You should have a plan. So you can't go on a road and then start, oh, where am I going? So that is this thing. So you were actually doing, but you were doing a bit too much. So you have to say, we will give you this thing, but immediately introducing yourself, asking the doctor what they know, what they want to know, learning objectives, which you said. And the good thing was you never forgot about the patient, You always have to remember, whatever task you have, whether it's a teaching or anything, patient is the thing. For example, it could be a gas. So where is the patient? Do you want me to see the patient? Is patient taken care of? Which you did, which is actually this is what we are looking at. So you didn't forget about the patient, because so you asked about patient, what happened? You actually reconfirmed whether he has seen an X-ray. This sometimes they will give you a pneumothorax, and then we side it is. So this does happen, come as teaching also. So this was well done. What you could normally say is, because you have to set, we say, I think we will have a slide. Do we have that slide? So we could.
Yeah.
So this is the basically slide which you can use in any teaching. Teaching, you don't have to know the knowledge. Any teaching, that's how you do it. First, understand the audience. It's like having a clear learning objective, which you clearly had. And then the main thing is structure your teaching. Set. You introduce yourself. You clarify the learning objectives. You gain consent. And in this case, it's important. You did actually mention we need to have a verbal consent from the patient, which is good. Then dialogue. Deliver the content interactively. You did it, but you were not able to complete it. So you have to aim to complete it. For example, as a primary survey, if you have not done A, B, C, D, E, log roll, you have not done it, you may have missed something. You get my point? So the aim should be, I need to finish this. And then closure. So like summary, key points, check understanding. What normally I do is when I start teaching this thing, when I'm telling what do you know and all. So at the same time, I will say, at the end of this thing, I'll give you some resources, just find you, so that you have done a closure, because this does happen that sometimes you're not able to close in the end. The best thing is to close it. But if you don't get time, it's always good to say. Communication, I think you were very clear. Your communication was actually very good. Interaction was really good. But how I would have done it is like, you told them, now, yes, we are doing this. This is how we do. Let me do it. Because if there is a dummy, they want you to do it, then you have to do it. So you could say, well, I'm going to do it. So you just observe how I'm doing it. If you have any questions, just let me know. We can discuss. And then while you're doing it, you ask the patient permission. While I'm doing it, is it all right? I can talk through. So at the same time, because you have to complete the task. For example, this is suturing. You can teach whatever if they want you to suture, and if you have not done that, so you have not completed your task. Is that right? So that is what you have. I think the way you started, the way you have good knack, but it's just you have to manage your time. Anybody wants to add
Yeah,
anything?
perfect. I think I second that, Hamid. So you got a very good communication skills, Raza, but
Definitely.
you need a structured approach. To be honest, in this teaching station, for the whole teaching station, what I would do, I will start with what I call initial package. Okay, so you took 3 minutes introduction, which is too long in this station. So initial package, introduce yourself, what your learner objective, what his level, and what does he know about what he want to know, okay? What he want to learn first. Okay, that's fine. We'll go through this. Okay, when we finish, I'll signpost you to some lectures, online videos, and then we can have a follow-up meeting within a couple of weeks to see how you're getting on. When we finish this, please send me a CBD so we can help you with portfolio. Less than 1 minute, you take many boxes, okay? This is the initial package. And then for all the procedures, what you want to say, consent, indication, contraindication, complication. Yeah? And then you can go through this one for the procedures, okay? And the Royal College of Emergency Medicine, they are stressed in all blocks about the safe dosing of local anesthetic, okay? So when you go to the complication, and then the local anesthetic. So safe dosing and safe administration is a crucial part of any block. Either it's an ear block, supraorbital block, mental block, facial yaka block. You have to engage this. Okay, and then just deliver in chunks. Good communication. Engage the learner. Usually, you ask them to repeat what you say. and they are trained to say it in incorrect way, and then you have to
Yeah.
correct them. It's a classic. It's a classic. Common is common. Okay, but well done. Very good communication. You just need a structure, and that's why we're here for. Okay. Anyone else want to give some feedback
Yeah,
for Raza?
just a few more points. Raza, you did well, honestly, but as Khalid and Hamid said, just slight polishing of your structure. So there are two things in the teaching. So everyone just listen. There will be two or three teaching stations in your exam. Two or three is a lot.
Minimum they will have that.
Minimum two or three. So you have to prepare. If you all take picture of this structure, use this structure, you got the 50% marks already. So number one is this structure, you have to use it and accordingly teach. And then second thing is you need to know the topic. If you do not know the topic, as Khalid said, in this station, indication, contraindication, dosing, and these things are very important. You might have any topic. So, but if you know the structure, at least you got the half of the number, isn't it? So if you know the topic, you'll get full. So be prepared for these and practice on the basis of this structure. So as Hamid said, understanding whom you are teaching. If it's higher trainee, probably different. If it's F1, if it's ST1, different. Then set dialogue closure, clear communication. I liked your way you said you are not knowing basically the dose. You said, okay, let's go together through the guideline. This is the easiest way. Okay, that's what we do. If I do not know the dose, we'll go through BNF, isn't it? So there, you should not shy. Say, okay, let's go through guideline together. No problem at all. Examiner will never fail you on that because that's what we do practically every day, isn't it? Well done. I think keep it up. Just polish it and know the topic and small objectives and engagement. You are okay in engagement. What I will do personally is I will break down the objectives into three small short objectives, and after each objective ask him, do you have any questions so far? Are you okay? Are you following me? Because definitely actor will have some questions. So just to make it 2 3 times so there is a good engagement between you and the actor. Yeah.
Good. Fine.
George, do you want to add anything?
Yeah, I thought it was really good. I thought your manner was really nice, really supportive, and you did all the things that have been said about finding out his the doctor's level of training already, etc. There's a lot to get into that station. A fast iliac block doesn't take 8 minutes, does it? It takes a lot longer than that. So if it was me, I would be writing down how to do all of these common stations and practicing at home to get it into the 8 minutes, so that you've got all these things from the slide covered in a structure in 8 minutes, because they're all common things that we do. So if you think of all the common procedures we do in ED that you on a regular basis will teach other people to do, have a structure for how you would do that in the exam, and then by the time you've practiced and practiced, it will just be second nature to you. But your manner was really lovely and really nice way of teaching. But you're right, there was a lot to fit in and you didn't manage to fit it all in, but you will do if you just practice getting it within 8 minutes.
Perfect. Okay, now we'll go to the next station. So next station, Mehdi, if you manage the timing, please.
Yeah.
George is the examiner. I will be the actor, and we've got Murtaza as a candidate. Are you ready, Murtaza? Hello, Murtaza?
Khaled, do you know the actors in this station or?
I am the actor in this station.
Oh, yeah. This is the first one. Do you know the story?
Yeah. Murtaza, hello?
Hello.
Hi.
Hello.
Are you ready for?
Ready?
Yeah. Yeah, it would be good if you open your camera as well, so we get a bit of interaction.
It's open.
That's good. Okay, it's fine.
Move the slide.
Yeah, you okay with the timing?
Yeah.
Start.
Yeah. Start.
Yeah. Hello, I'm Dr. Murtaza, one of the ED registrar. May I know your name and age, please?
Yeah, hello, my name is Ian. I'm 46.
Hello, Ian. How can I help you today?
Oh, doctor, I have a very bad abdominal pain. My tummy hurts a lot today. I'm feeling sick as well.
Okay, sorry to hear that. Can you tell me more about your pain?
Yeah, so this pain started today. It's all of there, so it's just getting worse. Like I have, I come a lot here, and they give me some fluids and some IV morphine, and then I'll be fine after.
Okay. Still, you are having any more pain? You need any more painkillers?
Yeah, yeah. If you give me some morphine, I think this the only thing works, to be honest.
Yeah, actually, they have given you just now, I think, sometime before morphine. If it is crossing 1 hour, then we will repeat your dose again if you are in pain.
Yeah,
Okay.
yeah, but I'm still in pain, so I need more.
Okay. So in the position, I will tell sister to give you some more morphine. Okay.
Okay, yeah, that's very good. Okay, yeah,
So can I ask you more about your condition?
yeah, go on.
Yeah. Can you tell me where is your pain mainly?
It's all over the tummy, all over,
Oh,
everywhere.
okay. So you are telling that you are having this pain since morning and it is very severe, this pain. It's right?
Yeah, it come and goes. Yeah, I have it a few times before. Yeah.
Okay. Is there anything that increases this pain
What do you mean? Anything?
with any posture, any movement, if the pain is increasing or anything?
No, it's just there. No,
Is there
nothing.
anything which is helping you to reduce the pain?
As I said, doctor, so if you look to the records, I come a lot here, and then they just give me the morphine, and then this is the only thing works.
Oh, okay, so I can understand with you. So can you tell me that today the pain was, how was the severity? From 0 is normal and 10 is the highest.
20.
It is 20, so it is more than 10. Okay, I
Mm.
can understand you. So can you tell me, is there anything else with this pain for you?
What? Anything else?
Do you have any vomiting or any other things?
It's just a pain, doctor. Is the morphine coming or what? Have you already asked the nurse? Is she
Already,
giving the morphine?
already I informed the nurse to prepare the morphine for you, and she will bring the morphine for you. Okay. And can you tell me,
Okay.
is there any changes in your bowel habits?
No, it's not the best. Yeah, but the same.
You are having some giving up, vomiting or something.
I'm feeling sick, but not actually vomited.
Okay, so you have only pain mainly and on the or on the abdomen. So you have any problem in your urination?
No.
No. So you have any chest pain or shortness of breathing?
No, not really. No.
You have any running running heart?
Any what? Sorry?
You have any palpitation or heart is running?
My heart is okay. You just keep asking all these questions, doctor. I'm just saying, like, I have the pain in the tummy. I didn't tell about any pain anywhere else. And what I need is some morphine. I'll be fine. I'll go home.
It's fine for you. Actually,
It's
we
just delaying now.
Yeah, I will give you the painkiller, and also we need to check you, and that's why I need some small history from you that to manage you properly. And
That's long history. It's not small, to be honest. You're asking too many questions. I just need the morphine, please.
yes, yes, I can understand your problem. And can you tell me this? You have any rash in your body?
Any what?
Rash.
Rash. I haven't checked, but I don't think.
Okay, you have any lumps and bumps in your body?
No.
You have any temperature?
I feel warm because I'm in pain and I need
Oh,
my morphine.
yeah,
So
yeah.
if you can help with that, it take too long.
So, sister, you have prepared the morphine for him. If possible, give him the morphine injection, second dose. And can you tell me that you have any headache or neck stiffness?
No, there's no headache, no neck
Any weakness
stiffness.
in your limbs?
Sorry?
Any weakness in your limbs?
No weakness in my limbs, no.
Okay. Can I ask some more questions for you? Do you have any previous medical problem?
So I have sickle cell disease. I've got this pain in my tummy, which come like every kind of other day or so. I go to A&E to get fluids and morphine, and then it just settle. Yeah,
Okay.
they've done everything for this pain. I have the scans before, CT, ultrasound investigations with the camera up and down. They couldn't find anything, but the only thing seemed to be settling it is the morphine, to be honest.
Yeah, I can understand that the sickle cell disease you are having, so which is causing you the more pain for this. As you have any previous surgical history?
No,
No surgical history. Do you are on regular medication?
no, not really. But yeah, just I'm just on a follow-up for my sickle cell, so they do blood test every few months for me. That's really, but it's fine, and it's kind of they said it's stable, so I'm not on any medication.
No. You have any allergies?
I have no allergies, but I need my morphine, please. It really take long time now, and you keeping asking 100 question, and
Yeah.
that's not helping as well. I'm more stressed now.
Yeah, I already informed the nurse, and they will connect you with the morphine, and also they will give some IV fluid for you. And I want to ask you some more. Where you are living and with whom you are living?
I live a bit far away from here, to be honest. But you are very good doctor, I can see, because like the any nearby, they always refuse to give me the morphine, and I went there a few times. But this hospital looks like sensible, so that's why I came here. I asked the ambulance to
Yeah.
take me here.
Yeah, actually, we have given you the first dose. That's why sister is making the gap, as we need to make a gap between first dose and second dose. That's
Yeah,
why
but
she.
in a lot of pain. I'm in a lot of pain. I need the morphine now. I don't need a gap.
So,
Like just suffering for long with
before
this gap.
morphine, we will give you some paracetamol injections. It will help
No,
you.
paracetamol is not working. It doesn't work. Paracetamol doesn't work at all.
Yeah, I can understand that, but it is, that we cannot give a second dose before the time, and we have to follow the timing maintenance here also.
What's the timing?
Actually, after the first hour, we have to wait for 1 hour more, then we have to give the second dose.
Why
Like,
you have to wait? Like I have to wait in pain for 1 hour. Why?
actually, we are having this protocol in our hospital protocol. That's why we have to follow this
No,
protocol.
that's not the protocol. I need some painkillers. I had paracetamol already and I had ibuprofen. So
Yeah,
I need some morphine.
yeah, I can
More
understand.
morphine, please.
And just, I think sister, she is preparing, and she will within the time she will give you now. Okay. And can you tell me that what you are doing for your living?
I work from home.
Okay. I can understand you. Do you have any more concern?
Any what?
Any concern? No.
Time is up.
Okay.
George, over to you.
Okay.
Yeah.
Okay, Murtaza, how did you think that went?
Actually, I didn't finish the last part of the management.
Okay, that's fine. It's difficult, isn't it, under stressful circumstances to get everything,
Yeah.
to fit everything in. There was lots that you did really well. So you introduced yourself really nicely. You asked the patient their name. You kept empathizing with the patient. That was really good. Really important to do that when somebody's in pain. So you kept saying, "I'm sorry that you're in pain." You didn't like the fact he was a bit confrontational, this patient, wasn't he? Just kept demanding morphine, but you stuck at your questions. You explained why you needed to ask further questions. People who are in pain can get irritable, can't they, and be confrontational, but you managed that really well. You explained about not giving too much pain relief. He was pretty insistent, this patient, that what he wanted was morphine. I thought you did ask all the questions required about abdominal pain. So you asked about the, anything make it better, anything make it worse, etc. You did a quick review of systems. That might have taken a little bit too long. You could just concentrate in this case, I think, on the abdominal pain, because a lot of the station was about clinical reasoning, and we didn't really get to see your clinical reasoning because you didn't start to get to the management bit of the station. What I would say, the patient was giving you some red flags. So personally, I wouldn't jump to just give this patient morphine. We see this a lot, don't we? Patients who say they've got abdominal pain tell us what pain relief they want. So you need to think about, is this possible drug-seeking behaviour? And he gave you some red flags saying that he doesn't go to his local A&E because they don't give him morphine. That's why he's come to this one. And he thought you were a good doctor because you were going to give him the morphine. So I think you just need to stick to you asked him a pain score. You got round to saying that you were going to give paracetamol, and it's good, isn't it, to start with those. We start with those medicines, don't we? Paracetamol, ibuprofen, and we work our way up the pain ladder. We don't just jump into morphine just because that's what the patient wants. If it had been me, I might have suggested that I would have a look. He's kept telling you he comes regularly, so I might have said, I'm going to have a look at your notes. Do you have a care plan? Lots of patients who come regularly to the department have a care plan. Do you have a care plan? Lots of patients with sickle cell disease have care plans saying what pain relief they should have. So I think there was lots she did well, but just remember not to just jump in and give the patient what they want, because if they are drug seeking, as this gentleman was in this instance, you don't want to reinforce that behaviour by giving morphine every time they come in. Is there another slide, Mehdi, about?
Yeah, there's a structure. Just remove the structure one.
Khaled.
Khaled.
Yeah. I think there's no slides after this. I'll be in the next station.
All right. Okay.
Oh, okay. Yeah, fine.
Yeah.
So, yeah, does that make sense?
Yeah, you can.
That feedback, Murtaza?
In the management, we have to say that we have to keep you in the observation room. We will connect you to IV fluids, and we will take some bloods for you, do all your investigations. And after that, if it is all is normal, then we can discharge you. And I have to examine you from head to toe, and I have to examine your tummy properly.
Yeah, I think with this patient, what I'd have been saying was, I appreciate you think you need morphine, but I just need to get to the end of the history. I'm going to have to do an examination. We're going to have to do some blood tests on you. I'd like to look at your previous notes. You've told me you come a lot, so I'm going to go and have a look at your previous notes. I wouldn't have
sorry,
just given
guys.
in and given the morphine. I don't know.
There is a slide, sorry. Yeah,
Yeah,
there's a slide.
no worries. So this, your communications, you stayed calm, you weren't confrontational, you were empathetic. I don't know what the other guys thought, but you did keep, Murtaza kept saying, I'm sorry that you're in pain. And that's what you need to do. You acknowledged that he was in pain, and said, I know you're in pain, I'm going to get you something for your pain. And you did say that you would give him more morphine. Yeah, so I thought you were empathetic. You did say, I'm sorry, I can't give it you right this minute. We need to wait the amount of time. There's protocols that we need to follow. So that was all good. But I think you just need to be a little bit careful. If somebody's a drug seeker and you just give in and give them what they want, which in this instance, this gentleman was a drug seeker, then you just need to be careful about that. And I didn't, because the time ran away with you, we didn't quite get to see your clinical reasoning. You didn't get to explain, as you just have done then, what your next steps of management would be. So just be careful about that. Has anybody else got any feedback?
Yeah, so I think I agree with all what Georgina said. You've got a good knowledge, but just time management again. So you need to practice, mate. You need to practice. Okay, not in 8 minutes, in 7 minutes. You need to finish this in 7 minutes because this will take more time in the exam. Okay, that's it, really.
Yeah, Murtaza, you did well, but only thing I'll tell, as George told, she summed up it very well. So you were focusing mainly on the history taking and information gathering. So you couldn't basically, because if you go to the pie chart, it has 3 domains in it. So you didn't touch the other 2 domains. So the clinical reasoning is half of it, isn't it? So you didn't manage the clinical reasoning. He was asking you morphine. You have to explain first from information gathering why he is asking for morphine. So this was one of the previous stations in RKM. So the station was set like, oh, you say you are sickle cell patient, then they normally give morphine to sickle cell patient. But he has given you red flags that I'm coming to your ANA only, so you are very good, this and that. So he is a morphine seeker. We have to take a proper history. Is he the morphine seeker? Then you can say, okay, let me do examination, let me take some bloods, and then we will start your painkiller like this will go up. So basically it was like proper clinical reasoning and decision making in this patient. You did some of the parts very, very well, but again, if in any scenario, if patient is asking you something, please do not ignore it. Do not ignore it. So you cannot. So if he's asking painkiller, you will tell him something like, can you tell me about more this and that thing. So you are ignoring him. So you have to answer to the patient's questions, and in a very polite way, isn't it? So I think clinical reasoning was missed here. And do not get preoccupied that you have to start history from this and finish it all the way till the end. So some stations are focused. You might not need to go the whole details. In this, he said skill cell, there was something hidden for the actor, that unless and until he will ask you drug seeking behavior, do not disclose. So that question basically was missing, because there's a morphine seeker. He did ask you from the beginning, morphine. You should have gone into that history, asked it in a sensitive manner, drug history, isn't it? So just need more practice, okay? And think about, if patient is asking something, is there something behind it? Why is he repeatedly asking this? Because this was not a mental health patient, isn't it? So mental health patient, sometimes you ignore their questions and try to complete your template. But here it was a different patient, isn't it? It was a conflict resolution. It was something difficult conversation. So the structure we showed you, try to fit that structure into this one. Take a picture, try to fit this into any of the difficult conversation patients, okay?
Yes. Thank you.
Perfect. Okay. So we'll move on to the next station then. See who's the candidate. So I will be this one. I will be the examiner. Mehdi, you are the actor. Yeah. And
Okay.
I've got Aksa
Yes.
on the spot. Yeah.
Oh, this is trauma patient, isn't it?
Yes. Yeah. You ready, Aksa?
Yes, I am.
Fine. Good. Let me just put the timing.
I just have a little query about these stations. So, because we are going to perform a phase, a primary survey and everything, so will someone continuously tell us the findings if we are asking them?
Of course.
Yes.
Yeah.
Yeah. Don't worry. Yeah.
Okay, that's fine.
Fine. Okay. You can start.
Who is doing timing?
I'm doing timing.
Okay.
Start.
Hello, hi, good morning. My name is Fatima. I'm one of the doctors, ED registrars here. I've been called to see a patient. Is that right?
Yeah, I'm the patient. I'm 12-year-old Tom.
All right, okay. So, right, Tom. Have you got any? Has there anyone else come along with you, Tom?
Yeah, my mom is with me.
Your mom is with you. Okay,
And
that's
I'm
fine.
one of the nurses. I'm one of the nurses called Julie.
You are one of the nurses, right? Thank you,
Yeah.
Julie. So if I'll need you, I'll let you know after quickly assessing the patient what's going on. All right. So Tom, is that right that you had an accident? Can I know more about it? What's happened?
Yeah, I just, came out from my house. I was about to, go to school, and then one car hit me and I fell down and I'm having pain in my abdomen.
Right. Okay. So, okay, fine. I'll ask you more about it. But Julie, can you please attach the monitor and if you could start monitoring?
Yes, doctor. Yeah, attach
Yeah,
it.
is that okay? So from this, I'll be starting my primary service. So from A, because Tom is talking to me, it looks like that airway is patent. So do we know how much is oxygen saturation for Tom?
So I attached the monitor in the screen, doctor.
Oh, okay. Right. So I can see that oxygen saturation are 92%. Heart rate is 135. Blood pressure is 80/55. Right. Can I quickly go on to the chest? Like how is saturation are 92? Is she on? Can we put on 15 liters of oxygen, Julie? Is that okay?
Yeah, I'll do that. Yeah.
Yeah. Right. And right. So respiratory rates are 25. On examination of the chest, can I see anything on inspection? Is there any bruising, any
No.
external injuries? Obvious, no. And on palpation, is this equal chest expansion that I've got?
It looks equal. Yeah.
Yeah. All right. And on percussion, is there any different note or is it normal?
No, it's resonant bilateral.
Right. On on auscultation, is there equal
air entry?
Equal air entry. Fine, fair enough. Right. Sorry, Tom. I'll be going to feel the tummy, but you mentioned that you are in pain. Is that right?
Yeah.
Okay. Julie, is that okay if we could get some IV cannula in and some blood tests, full blood count, coagulation profile, and venous blood gas for this patient? And
Yeah, we'll try.
yeah, and meanwhile, before getting the IV cannula, can we give Tom some painkillers, maybe intranasal diamorphine? Is that okay?
We'll do that. Yeah.
Yeah. All right. So on examination of the chest, am I able to hear the heart sounds fine? Yeah.
Yeah.
Yeah. So blood pressure is also on the lower side, and child looks tachycardic as well. So if we could attach IV fluids as well, that's okay.
I can't get a cannula on him.
Sorry?
I can't get a cannula on the patient. I tried twice.
You have tried twice. Okay. Do you think you will be able to get anyone from any help from A&E if we have got any colleagues, or maybe call pediatric team over there so that if they can
Yeah.
help the cannula?
You want me? Yeah, I called them. They on the way, but everyone is busy. It's just me and you.
Right. Fair enough. Okay. So is there any finding on the, I'll come to you. I'll come back to you, Julie. So can I ask if there is anything on the abdomen that we can feel on inspection? Is there any obvious injuries?
There's bruise on the upper abdomen, and he looks very uncomfortable.
He's got bruise on the upper abdomen. Yeah.
Yeah, and the patient looks very uncomfortable, and he's a bit less responsive now.
Less responsive now. Okay.
Yeah.
So on now I can see that there's a significant finding that I found on the abdomen. Patient is not responding as well. So Julie, if you could call pediatric trauma call, if you could ring, and we'll start from the A now. How is the child's airway? Is Tom? Are you okay?
Yeah.
So Tom is still speaking to us. How is his SpO2? Is it still the same? We've got oxygen on. We've assessed breathing, now on circulation. We have put a pediatric trauma call in already. Have we got any help? No?
No, not yet.
Okay, so I can try getting an ultrasound cannula. If I'm not able to, maybe we'll go to IO intraocular.
Yeah, I managed to put a cannula.
You have managed to put a cannula. That's wonderful. Okay, so we've got
Yeah,
fluids.
I've done a gas as well.
Done a gas as well. Okay, right. So pH looks fine. PCO2 is okay as well. Lactate is 3.1. Glucose is fine. Right, fair enough. So patient's lactate is high with significant abdominal injury. So have we got anyone back from the trauma call? Any specialty that we have got? Not yet.
No one yet. Not
Okay.
yet, no.
Right, fair enough. So have we? Can we activate major hemorrhage protocol as well, because we don't know what
Yeah, we can do. We can do. I've got a cannula, doctor. Don't to give the patient anything.
Have we started IV fluids yet or not?
Yeah, we can do. How much fluid do you want?
So that is according to the wet flags. So if this is 12-year-old child, so 10 mils per kg, start with that, with the bolus.
What fluid do you want?
So start with sodium chloride for now.
Okay.
Yeah, and meanwhile we have activated major hemorrhage protocol as well. Is there ultrasound there so that we can do a fast scan?
Yeah. There is ultrasound.
Okay. Looks like there is some fluid around the kidney and the liver. So that is on the right upper quadrant. Looks like that we have got some fluid there. So I think that is again the significant finding. So, all right. So we have what we have done so far is we have managing airways. Tom still talking to us?
Yeah, he's been morning, less responsive morning.
Right.
Yeah, we finished the first bag of fluids. Anything else you want to do?
And is there any blood arrived yet? Have we got any blood products?
We only got only the gas. We've got blood products if you want.
Yes, please. If we could start patient on ONEG while we are waiting.
How much ONEG do you want?
And I think it is the same as the 10 mils per kg that we start with the blood product. We'll start with the blood product. Breathing we are still okay with. On the circulation we are concerned about there is maybe hemorrhage inside the abdomen. We have put on pediatric trauma call. Hopefully we are going to get them very soon. And meanwhile, Julie.
Time. Okay, Aksa, well done. How do you feel about this?
I think what I did bad was because
so don't say the bad thing. Say the positive thing first.
So like I did not know that patient, like is he, because if he's talking to me, like in what position he is in exactly, like he's brought in by his mom, is he actually sitting in front of me, or what position is he in? So because we normally, if it is like practically you will be able to see the patient like from the look of it, like in 5 seconds you'll be able to assess like what you are going to do next. But I think I should have put the trauma call if I'm thinking of pediatric trauma significant like this, so I should have done it earlier on, I think, from the start. But yeah, I think I did it little bit later.
Yeah.
I thought that I'll be able to manage it on my own. It is not that serious, but yes, it was absolutely. But yeah, I think it was okay.
Fine. Yeah. So I think your communication was fine. You kept calm, focused. Okay. You got a good A to E approach, but you haven't completed it. Okay. When you look to this station here, you're still in the 1 minute outside. Okay, standing outside reading this. So you have been called to manage 12 years old child who injured in RTA. Okay. So what do you think about this? Now, you got 1 minute. So you read that in 10 seconds. You get 50 seconds. What's going in your mind?
So, yeah, I think again, I because I didn't know like what exactly type of, was it like a major thing as like
what is this station?
Sorry? Trauma.
What he's saying.
Trauma, resuscitation.
Yeah.
This is the resuscitation station, isn't it? So you have to plan for a resuscitation. Trauma trauma resus, yeah? So you have to, only one senior nurse, young patient, child in RTC with one senior nurse. That's mean we are in a trauma, yeah? So when I'm going in, introduce yourself, make sure to everyone know you are team leading, know who is in, what's the level, okay? If it is a patient not arrived, so prepare with flags and seek help early.
Yeah.
Seek help very early.
Khaled, just a point here to add.
Yeah.
When you see in the scenario, in any scenario in exam, you have one doctor, junior doctor, senior doctor, or a nurse. Think about it's a resuscitation, okay?
Yeah, absolutely.
Yeah.
Yeah.
I think
And that's why,
I just didn't pick it up early like that. It is something serious going on. So I
no,
think
that's why
kind
we
of
are here.
simple.
Yeah. That's why we are here to guide you. So
Yeah.
you're going for resuscitation. So in this 1 minute, okay, so what I'm going in, introduce myself, know everyone, allocate rules, get with flags, escalate early. You need to escalate to the any consultant because you're still a registrar.
Yeah.
Okay. Is there any consultant here? You need to know first, it's a pediatric trauma, activate the trauma team. Okay. And then start speaking to the patient, do A to E assessment. Okay.
Right.
Fine. And then when you're doing A to E assessment, first one is A. Yeah, what's A?
So airway. So I just
You just done your ATC.
yeah, A is
Airway plus what?
airway and C spine. Then we start with
Yes, airway, C spine, and analgesia. I'll put analgesia as well. And A. You offered analgesia, I think so, which was good. Airway. So airway is patent. Okay. He was talking to you, which is good. If he's not talking, try to do like simple maneuvers for airway, head tilt, chin left, jaw thrust. Okay, some suctioning, MPA, oropharyngeal, all this in your mind, and then go back. Any intervention you do in the trauma, you have to go from A again. Okay, when going down to breathing, so you put oxygen straight away because the saturation was 92.
Yeah.
Okay, and still in the airway, apply oxygen. Okay,
Yeah.
that's fine. And then C spine, we don't usually put like a C cooler now. We trying to move away from the C cooler in pediatric. Okay, so if you're worried about the C spine, just try as much as you can to stabilize it. Maybe use a bit of blankets, okay, maybe a bit of blocks if needed, but don't restrict. Don't restrict. Even ATLS and ATC, just away from restriction. Because it harm more, isn't it? And then you're going down. So start with the trachea. Is the trachea central? Is any subcutaneous emphysema? And absolutely, as you done in the P. Okay, so look to the chest, see if there's any chest deformity, echo rising. What is the respiratory rate? Okay, percuss, auscultate, good. And then go down to your C. What do you do in C?
So heart rate, blood pressure, cap refill time.
Have you done the cap refill time?
I think I forgot.
Yeah, that's very important, children. And it guides as well your resuscitation. Okay, if you're resuscitating with fluid and it guides you. Cap refill time, good indicator. Okay,
Yeah.
what else?
So blood pressure, abdominal examination, extremities, so all those things. Any
Extremities, look to the patient. Is the patient looks well perfused? Is he pale? Is he clammy? Yeah. Cap refill time, heart rate, blood pressure, and then abdomen.
Yeah.
As it done? Pelvis, apart from the C.
Yeah.
Because it can lose. Yeah, so put a pelvic binder. Okay. Long bones.
Yeah.
They can lose a lot of bone. Yeah.
Yeah.
Any external hemorrhage? So all this in C. And then you haven't reached D?
So I think, I should have told properly, but I think if the patient was speaking to me, that's what we have done yesterday. The A person is normally, obviously I have to tell that I'm doing D at the moment, but if the airways person is assessing D, they're if the GCS patient is talking, assuming GCS is 15 and
no, don't assume anything in the exam. Don't assume anything. No one will be assuming. You know. Okay, so you have to verbalize and do everything because it's a test. It's an exam. Okay, and again, this is with practice. So D and E and then reassessment. Okay. Good. Now, with a fluid resuscitation in trauma, okay, there's a wet flag. How much fluid do you give? Usually crystalloid.
So I actually skipped my mind because normally, like, I didn't do the right thing. Like, obviously on the pediatric,
That's fine.
I've got red flags
Yeah,
already written, so we
yeah,
don't work mind up
absolutely. Don't
according
worry.
to that.
So usually we would be worried about cerebral edema, giving a lot of fluids in a medically sick child. Okay, so we give 10 milligram per kg. But in trauma, we give 20 ml per kg crystalloids. Okay, and if we reach it like 20 ml per kg and he's not really responding, so we need to start with blood, or if there's evidence of a hemorrhage, a significant hemorrhage, we can start with O negative, which will be 10 ml per kg. Yeah. You can consider tranexamic acid as well
Yeah,
as a
that's true.
patient is, and you already activated the major hemorrhage protocol. So well done. It just need a little bit more modification. Pace need to be more fast, yeah, faster, and you need to get through all the A to E assessment because the resuscitation trauma station is the easiest one. Should be the easiest one in the exam. Okay.
Yes, hopefully next time, and think in the next session I'll be better, because I just was a little bit overwhelmed through the online session because
Yeah, absolutely.
yeah, so I think I'll do it better when next face-to-face time.
Can I
Hopefully.
add something?
Yeah.
Yeah,
So
yeah, Hamid.
in any trauma scenario, you have to make sure you do A to E assessment.
Yeah.
Then you mention log roll. Then you mention urgence. If you have not done it, then means you have not completed the task. So, for example, at B, you had a problem. For example, you have a hemothorax. So you still want to do C. So what you could say that time is, can you prepare chest drain? While you are preparing chest drain, I will try to complete mine, because you read excess before you put a drain in. So you try to do it. So you give us that, can you prepare this while I'm doing it? Because you have to complete, and now whether a person no. When in trauma, when you are in exam, you are the only one. You have to ideally do a trauma walk, start from there. And if they want you to do some skill, they want you to do some skill. They want you to size the collar. They want you to, or they may have somebody you have to teach him. So basically, you have to consider you are the only one who is doing it until they tell you that you have to do the other way around. They may give you help if you want somebody. They will say, "Oh, we'll put a chest drain," but you have to make it sure that you have to complete the task. And when he said 2X's, he couldn't get in cannula. It's straight away you have to say IO.
Yeah.
Nothing ultrasound guided, can somebody help? No, you are the one there. So you have to forget about it. Can I get a help? You know that they're not going to give you help. They are mean there because they want you to do it.
Yeah.
So you have to say, yeah, can I have an IO?
Yeah, that's.
Then they will say, as he said, you said IO, he said cannula is there. That's what we want there. We are basically, that's what we are testing, your decision making. All right?
Perfect.
Good.
Yeah. George, do you
one
want to
thing
say
to add.
anything? Yeah, Mehdi, yeah.
Yeah, just one more thing to add, as Hamid said. So in ATLS scenario, you will have one person, that's the only one person. If you did ask help, you have to ask help, but forget about after that. So they will say they are on the way. You have repeated 4 times. Is help here? Have I got anyone else? So you do not need to repeat that. You wasted those 5 seconds for asking. So because he wanted you, oh, I failed, I couldn't do the cannula. Straight away, IO. And why IO? So you put IO. He is giving the numbers. Patient is tachycardic, hypotensive. So you have to fix that. You cannot move and leave that, go here and there, or ask for help. So if someone is coming from other department, by the time patient will die. So you have to fix. So he wants you to fix that. So IO and start some IV fluid and arrange blood. So that is. So basically, it's a leadership role. You are a leader, you are a trauma team leader at that time. You might have only limited number of people available. So say you need help or trauma team activation, but they will never arrive in your scenario in MRCEM. Never ever. Forget about that.
Yeah,
so then
Yeah.
he is giving you hint, oh, patient is deteriorating. Think something is missing. Something is missing. You didn't, if you do not, know that what's missing, go back to A, B, C, D, E. Okay. In that way, you are absolutely fine in this, but you need more practice in such scenario. And as Khaled said, this is the easiest station to mark high. In ATLS, you can get 10 out of 10, 9 out of 10. This is easiest, you know, it's ABCD, it's nothing more than that. There are 4 or 5 pathologies you will get. That's easiest pathologies to pick up and treat, isn't it?
Yeah.
And
Yeah.
as Hamid mentioned, if you have to do some procedure and you won't continue to complete the assessment, you can say, okay, while we are doing, if there was a doctor with you, said, okay, I'm okay to do IO access, right? You can say, okay, while you do IO access, let me complete D and D. Yeah.
Perfect. Yeah, and for
Thank
the
you.
practice, what we do in our courses as well, guys, when we finish the course, we are not done. So we put you in a WhatsApp group so the candidates can get some practice together, and then one of the consultant will jump in this practice session to guide you as well. So we keep supporting you after the course till your exam. Okay, this is
Thank
extra
you.
bonus thing. George, you want to add on?
No, I think everything's been said. I thought you were methodical and you had a structure. It's obvious you can deal with trauma and you've got a structure, but yeah, they're just the points that have already been made, which I think you realised. You could tell you were realising that yourself as you were going along. But no, with practice
Perfect.
you'll be absolutely fine, Axel.
Thank
Good.
you.
And then there's 2 hands
Can I
up, Murtaza and Muayyad. So start with Murtaza. Any question?
Can you hear me?
I can't hear you, mate, at all.
Can you hear me?
Yes.
Yeah. Good morning. Well, I don't know if it's time, morning or afternoon. Thanks for this informative session. Just one question for like this system case. At the end of the task, if we finish the task via the time, can we just hand over the patient for مثلا trauma team and we clinical decision making? We advise them this patient should go to
So
operating room.
if someone arrives, you can hand over to him. Or sometimes the nurse, if you've done everything, if like you are kind of outstanding, you've done your trauma survey, resuscitation, everything, and you've still got time, she will ask you where this patient going, doctor. And then you
So
will
we
start to
decide.
suggest. But if someone arrived like from the surgical team, so you can hand over to him.
Yeah, and normally in trauma cases, there will be like short S-bar type handover. Most of the time, it is surgeons, neurosurgeons, or orthopedicians. So most of the time, there will be definitely short S-bar type handover. Most of the times.
And in the
Perfect.
beginning, can you ask if there is any catastrophic bleeding before starting?
Yeah, absolutely, you can.
Yeah,
Yeah.
then you have to do that.
Yeah.
Yeah, before starting, there is any obvious catastrophic bleeding. So then after that, shall we make?
Yeah.
Yeah.
Thank you. Thank
Good.
you.
Good. So I hope you all enjoyed this session, guys. And any questions so far about the exam and the station we've done? There is the hand up. Yeah, feel free to ask. NP.
Yeah, I wanted to know, like, there's July session coming in Hyderabad, and it is
Yes.
3 days. So
Yeah.
what is the format like for all 3 days?
So the 3 days will be 2 days extensive, kind of small groups. We'll do practice, feedback, hands-on, and then the 3rd day will be a MOOC exam.
All right,
Guaranteed to
thank you.
pass.
Hopefully, yes.
Is that a good answer?
Yes, thumbs up.
Okay, perfect. Anyone else, guys? Perfect. So this is our website here. Can have all. Yeah, so on our website, all the courses there. We have 2 sections as well, which is a revision guide to MRCEM OSCE and FRCEM OSCE, just free. You can go to the website, go to your MRCEM revision guide, and you'll find all the station with a structured approach, all written for you, very detailed, very good, and highly recommended to go through this before you start practicing. Not all the station been uploaded yet, but we're uploading it one by one. So get benefit from the one already there. So this is our website. We've got the Facebook as well. You can just Facebook group and Telegram group to support you through your exams. So you can join this as well and reach us anytime if you need any help, any hand. And we are very happy to help. Anyone have a last thing to say? Mehdi, Georgina, Hamid?
Just one more thing. Those who have booked our course on 24th and 25th, if you want to practice in group with other colleagues, and if you want add us to create a WhatsApp group for you, just write down to Khaled. He will create a group for you so that you can start practice with each other from now onwards. And there will be consultants around. If you have any question, we are happy to answer that.
Which will continue till your exam, those who attend the course.
Okay.
Perfect. Thanks very much, everyone, for coming today. Thank you, George. Thanks, Mehdi. Thanks, Hamid. And all the best for your exam,
Thank you.
guys. And enjoy the rest of your weekend. Bye.